So chronic heart failure or congestive heart failure is an inability of the heart to circulate adequate blood to meet metabolic demands. There's two ways that congestive heart failure can originate from. It could either originate from the systolic or diastolic portion of the cycle, which is we are going to be looking at a lower than normal either a lower than normal contractility or failure of the left ventricle to properly contract or relax, respectively, depending upon which part of the cycle that you're kind of dealing with. So individuals with a systolic congestive heart failure will have a reduced ejection fraction, which is basically, you're essentially just looking at a reduced pumping ability of the heart. And many times you see this in individuals, particularly who have had myocardial infarctions or heart attacks, while those with diastolic failure have a normal ejection fraction, but they have a lower stroke volume. So the reason why they would have a lower stroke volume is with the diastolic origin, you get stiffness in the ventricle. So basically the ventricle doesn't fill up as much as it does. So there's difficulty with filling. So you end up with a reduced end diastolic volume, which is then going to lower the amount of blood that gets pumped out when the heart goes to beat. So kind of from a mechanism standpoint as to how this affects the person will depend kind of which side their chronic heart failure, congestive heart failure could be coming from. So your chronic heart failure may be the result of either an ischemic or non-ischemic etiology. So an ischemic etiology, for instance, would be like, for instance, a myocardial infarction, which is a heart attack. We'll be talking about that a little bit more later. Or non-ischemic, something like a chronic hypertension. So either one of those can contribute to chronic heart failure. So due to the reduced cardiac output and stroke volume, what's going to essentially happen, in order to maintain blood pressure, the renin-angiotensin and sympathetic systems are activated. So basically what this is going to do is, in order to maintain blood pressure, because you're having reduced cardiac output and decreased stroke volume, your body tries to maintain its blood pressure by basically causing vasoconstriction in the blood vessels. So over time, because then there's greater resistance in the vessels, that could also cause cardiac hypertrophy, and you could also then continue to get continued stimulation of the sympathetic response. So you're basically getting the sympathetic response all the time when obviously your body doesn't need it. And individuals with this can deal with severe exercise intolerance due to lactate accumulation at low exercise levels. So basically what this is saying is you're essentially going to kind of lose some exercise tolerance related to this, or just activity, your ability to tolerate any type of activity beyond rest would be, could possibly start to be compromised. If we look at medications, so digoxin is actually a medication that'll increase cardiac contractility. So what that could do is compensate for low stroke volume. So basically it'll help with the myocardium contract. Beta blockers will actually lower the heart rate. Diuretics can be used to reduce blood volume overload. ACE inhibitors can reduce blood pressure. So we've talked about diuretics and ACE inhibitors, or they've also been connected with obviously managing blood pressure as well. And then cardiac resynchronization therapy could use to resynchronize the contractions of the ventricles. So this is something that can also kind of be done to help in treatment for an individual, depending upon the cause or the background related to their chronic heart failure. So we look at the effects of exercise. So the biggest thing we're going to have to look at is initially individuals with this are going to have much lower levels of exercise capacity. So again, you're going to see greater shortness of breath, fatigue, and a lot of lower workloads related to what it is they can tolerate because of those, kind of because of the pathology itself, going back to what we discussed. Medications can improve the response, but also have effects on heart rate and blood pressure. So depending upon the medications they're utilizing to treat this, which again is going to be based upon the cause of it, that could also impair their body's response to exercise. So if they're taking, for instance, if they were to take a beta blocker to lower their heart rate, that's obviously then going to impact their exercise as well. So you have to be mindful of that. And then that kind of goes into, some of the other things we look at. So intense exercise, has shown promise actually, and actually may be safe for some individuals. So again, depending on their abilities, they may be able to do more intense exercise. And at one time it was thought that, any type of intense exercise for all individuals was going to not be something you would be looking to do. However, they have found that for certain individuals, it can actually help to increase a lot of their markers. It can help increase their VO2 max, their cardiovascular efficiency, and a lot of their, kind of just peripheral responses that they get to the exercise. So there is room, depending upon, and in all likelihood, one of the things that will dictate that is what's the person's general fitness level or their general health to start with, can kind of dictate some of that. So your exercise recommendations, again, you have your table summaries. Of course, I'll talk about some things here. Again, exercise testing should be done maybe just to determine the lactate threshold. Again, this can be used for accurate exercise prescription when you're looking at this. Again, similar recommendations to some other things, large muscle aerobic exercises. You have your percentage of VO2 or heart rate reserve, so you could kind of monitor that. Again, heart rate could be a little tricky at times, so you do have to watch that. So if heart rate is not an accurate intensity measure, you can use the ratings of perceived exertion. So always remember, ratings of perceived exertion is always an option. A lot of people in general, interestingly enough, just as a side note, RPE is being used a lot more in programming. I've found just even in kind of some just some trends in like programs that people write up, they tend to be going more towards that. So a 12 to 14 RPE can be used. And if they're cleared to participate in it, they can do higher intensity training. So again, a lot of this will be based upon, again, what type of medications are they taking? Maybe even in the past, kind of what's their general fitness, wellness level at the current time. And then that could kind of determine some of whether or not they could do some higher intensity training. So your resistance training, again, you could use circuit training, 40 to 80%, so a little bit bigger range. You may have to go a little lower intensity for the individual. And again, regular activity of any types and avoidance of long periods of inactivity should be encouraged. So again, these would be the individuals that you may even want to, very much so encourage, if you were training with someone like this, encourage them to go for like even short, frequent walks would be something that would certainly be of benefit to individuals who have chronic heart failure. So myocardial infarction, again, commonly referred to as a heart attack. It's a reduction or a cessation in blood flow to the heart tissue caused by a clot or blockage of the coronary blood vessel. So the coronary arteries are the blood vessels that supply the heart. We all know that we look at the heart as kind of the supplier of blood flow for the rest of the body, but the muscle, the heart muscle needs blood, needs blood and oxygen as well. So it's the coronary arteries that supply that. When you get a blockage, either caused by, again, a blood clot, or possibly a blockage caused by an atherosclerotic plaque, that will cause a blockage and reduce blood flow to the tissue and cause the myocardial infarction. The severity of it's going to be based on the amount of tissue that gets damaged and the extent of collateral blood flow. So, again, it kind of depends here on where the blockage is going to take place, how much of the tissue has actually had reduced blood supply, for how long they've had reduced blood supply for. They usually recommend an intervention within 2 hours of chest pain. So if a person starts to have chest pain that looks like it's of cardiac origin, it's very important for them to get care as soon as possible, because you can avoid a lot of complications Usually, within 2 hours, many times they'll try to do a percutaneous transluminal coronary angioplasty, which we'll talk about as far as a surgical intervention for this. Basically, they put in a little catheter, and on the tip of it, there's a balloon, and they kind of open it up to reestablish blood flow. If that could get done fast, you really decrease the amount of secondary damage and reduce complications associated with it. So again, clots are usually going to be the result of an atherosclerotic lesion. There are obviously, other reasons why blood clots could form, but that's usually the more common thing we tend to see in these individuals. And here we have all the various risk factors that are associated with that. We've talked about blood lipids and kind of what that means. And here's some of the other factors listed. Usually the more common places where you're going to see the plaques rupture are usually going to be at the blood vessel bifurcation. So kind of where the blood vessels kind of branch off. And the reason for that is the blood flow tends to get a little turbulent in those areas as it's going through. So that just kind of increases the chances for the plaques to kind of rupture off, and then they kind of get lodged and will block blood flow in some part of the artery. So when we look at the medications, again, the purpose of a lot of the medications is going to be to reduce the work of the heart and maximize blood flow to kind of minimize the tissue damage following a myocardial infarction. So that's going to be some of what gets done here. So again, your beta blockers and vasodilators, they're going to reduce the heart's workload. So again, if it's going to slow down the heart or cause vasodilation, which is basically going to mean that there's going to be less resistance to the blood coming out of the heart, that's going to reduce some of the workload. ACE inhibitors will reduce some of the afterload because, again, that's going to impact blood pressure. Plavix is going to thin the blood and reduce the chances of any more clot formations. Statin drugs, many times, if they haven't already been given to individuals, will likely be prescribed at that point. And again, calcium channel blockers are another thing that can reduce afterload. So it's important to look at, some of these medications can improve exercise capacity, but if they're going to affect heart rate and blood pressure, that's obviously going to impact kind of their response to exercise. So again, for instance, if someone's on a beta blocker, it's going to lower their heart rate. If they're taking like a calcium channel blocker, again, that's going to reduce their blood pressure. So, the impacts of that, you just kind of need to be aware of when you're prescribing intensities or you're kind of, if you are supervising them for different responses. So as far as the effects of exercise, again, the effects and benefits they're going to get are individuals who've had myocardial infarction are generally going to be the same as for healthy individuals. So you're going to get your increased VO2 max, increased cardiac efficiency, and weight loss. The response, though, sometimes could be blunted due to the amount of cardiac tissue damage. So again, that's going to kind of dictate how well a person's going to tolerate. Going to be one of the things that dictates how well someone's going to tolerate exercise after having a myocardial infarction is the amount of cardiac tissue damage. No exercise program should begin without a medically supervised exercise test and a period of supervised training. So they should likely be giving, for instance, like a cardiac stress test and everything, prior to any just, regular exercise program. You also want to be aware of any comorbidities that may have either caused the myocardial infarction or are the result of it. So, do they have, do they still have angina relative to it? Do they have heart failure? Are there conduction issues? You want to be aware of that. Many times, though, as well. So, I brought up the conduction issues, but sometimes exercise can actually help. Properly prescribed exercise can reduce some of the symptoms that they may have after the fact. So it can actually decrease, again, if they're led into a good program, it could actually decrease the chance of them getting an arrhythmia. Is one thing you can do. And in general, it could also reduce the catecholamine response to exercise that's going to happen. So over time, they'll get that as an adaptation. So your exercise recommendations, again, you have your tables here to look at. One thing to note in particular is utilize an extended warm-up and cool-down. Strongly recommend it. Arrhythmias are more prevalent during those times. It could also kind of give you an idea as to how the person's going to tolerate the exercise. Also be aware of temperature extremes due to the medications. Because again, that could affect some of their exercise tolerance as well. Again, large muscle groups on aerobic activities, at least 3 days or more a week. Here you have your intensities here, and then 20 to 60 minutes. Again, that could be continuous or accumulated. Your resistance training, 40 to 80% of a 1 repetition max. And again, you can use circuit training stations could help with that as well, because it can also kind of, in addition to obviously strengthening them, it could kind of help their continue to help with their cardiovascular and aerobic responses. Okay, atrial fibrillation. So atrial fibrillation is one of the more common types of arrhythmias. So an arrhythmia is any type of disturbance in the heart rhythm. Again, if you kind of go back, so you got to be thinking a little bit about what we had talked about in the 240 strength conditioning class. Remember when we talked about the cardiovascular system? You have your atria and your ventricle, and your ventricles, and your heart has its own kind of cardiac conduction system within itself to kind of regulate the contraction of the atria and the ventricles, because that impacts the blood flow through the heart and then out of the heart. In the case of when we're talking atrial fibrillation, again, that's going to be your most common arrhythmia. There are a couple others that an individual could have. That one, just the most common one. The atrial fibrillation is an electrical malfunction where the atria depolarizes very rapidly, and that results in an uncoordinated ventricular contraction. So remember that kind of internal electrical conduction system that the heart has to function obviously in a very coordinated fashion to consistently pump the blood throughout the body. And if it doesn't, obviously, besides the fact of sort of like messing up the circulation and how the blood goes through the heart, one of the more common things that happens in individuals with atrial fibrillation is the development of blood clots. So what, a lot of times the treatment that people will get, as we'll talk about in a little bit for this, are done to prevent clots that occur due to the atrial fibrillation. So, and this is present in a number of conditions. So again, hypertension, heart failure, coronary artery disease, and valvular heart disease, which is something else we're going to talk about. These are all conditions that atrial fibrillation can be a part of. So I'm looking at the medications used to treat this. So I'd already mentioned the occurrence of blood clots being a high priority to make sure to manage. So things like Coumadin or warfarin, which is basically when you hear people talk about taking blood thinners, that would be your blood thinner. Plavix is another thing. Or they could take medications to possibly either change the contractile ability of the heart, lower blood pressure, lower heart rate. Could certainly be things that can be used. And again, this could help control the ventricular response and improve exercise capacity. So exercise can actually create a greater than normal ventricular heart rate when individuals have this. So that may be something that would need to be dealt with through medications. So the effects of exercise, again, atrial fibrillation is going to reduce stroke volume and cardiac output, and that's going to result in a lot of your early fatigue. So again, you have to be aware of the effects of exercise on the underlying conditions as well. So if the individual does have other conditions associated with the atrial fibrillation, you need to be aware of that. And again, any symptoms that they would have as a result of exercise. So again, you have your exercise recommendations. Again, the tolerance is going to vary between individuals, and a lot of times it's going to depend upon, what type of comorbidities they have or what other type of conditions they have associated with the atrial fibrillation. So again, if they have, heart failure, if they have hypertension, how does that relate to the individual's exercise tolerance? And they should have a medically supervised graded test, again, because that can just give you a better idea as far as the proper exercise intensity. So again, here's your general recommendations for your aerobic activities. Again, rating a perceived exertion of 13 to 16. It'd probably be a good idea to really familiarize yourself with the whole concept of a rating of perceived exertion, particularly if you're going to be working with these special populations, because many times that ends up kind of being almost a better marker. Plus, it's just easier. You don't need any really fancy equipment to do it. And again, in the case here, heart rate might not be reliable for these individuals, particularly if they're taking a medication that impacts their heart rate. So again, that's something to be mindful of as well when you're kind of looking at and sort of determining your exercise intensities. So resistance training, again, 40 to 80%, 1 repetition max, 2 to 3 days a week. Again, you could use circuit training would be very good. Again, just in general, active lifestyle should be encouraged. So, again, even beyond structured exercise, again, going for frequent walks and things of that nature will certainly be a benefit to all of these individuals, as it would be to anybody. And again, in this case, again, this is another situation where some more high intensity training could be appropriate for certain individuals. So again, doing some type of, higher intensity conditioning, if it's appropriate for them based upon, again, medications they're taking and things of that nature, it can increase some of your training outcomes with these individuals. So looking at pacemakers and implanted defibrillators. So again, there's conditions that may create the need for a pacemaker or an implantable cardioverter defibrillator. And those are going to be conditions that are going to cause some sort of conduction disorder in the heart. So any electrical disturbance in the heart that results in a high, low, or disorganized heart rate, which again, all of this can cause lightheadedness or syncope. So essentially, any one of those things would call for the need of possibly using either a pacemaker or a defibrillator to treat that. And again, the idea is there for them to restore and optimize the heart rhythm. So again, both of these devices are going to be used to maintain a normal heart rhythm for the individual. Again, the underlying causes range from various conditions. You look at coronary artery disease, heart failure, myocardial infarction, or what we call sick sinus syndrome, which is a sick sinus syndrome is it's an aging-associated degeneration of the sinoatrial node. So, and again, the sinoatrial node, atrioventricular node, those are both parts of the heart's conduction, electrical conduction system. So that you'd be looking at as some of the various conditions that would call possibly for the need of one of these two devices. And again, the idea is you need the abnormal heart rhythm corrected to avoid any future tissue death or just general insufficient blood flow. So, and again, there's various types of abnormal heart rhythms. Your textbook talks about some of them. There's the bradyarrhythmia, which is an abnormally slow heart rate. You also have what are called heart blocks, where there's a delay in the electrical conduction system throughout the heart. So, which creates an interruption. So any of those things would need to be treated possibly with a pacemaker or a defibrillator. So in looking at medications, again, in most cases, the pacemaker or the implanted defibrillator is going to be the treatment itself, but these individuals in all likelihood may be on some other type of medication to treat their comorbidities. So again, you'll be looking at what's the cause or what's the need for the pacemaker or defibrillator and determining that. So if we look at the effects of exercise, so again, exercise capacity, should be improved with the use of the device, because obviously if the device is going to normalize the heart rhythm, that should help that. However, you do have to realize that the exercise may be affected by the presence of the other conditions. And if the pacemaker is effective, the response to exercise training will be consistent with the expectations associated with the underlying comorbidities. So the idea here, the increase in quality of life, from that should be, good with the pacemaker. And the idea would be to be able to just perform, exercise and activities of daily living without some of the symptoms that they may be having. So some of the symptom relief you're looking to get are things like the dyspnea, the hypotension, the lightheadedness, syncope should hopefully all be corrected. And that should be, further carried on by the benefits of the exercise. So again, you have your exercise recommendations. Again, medical clearance related to the comorbidity should be obtained. So again, you want to make sure that the exercise is prescribed in light of these other conditions. So you're seeing that with a lot of these things where, again, comorbidities. So, that's why having good awareness of all these conditions and how one could affect the other becomes very important. For the first few weeks, you want the exercise to be at a lighter intensity to not alter the integrity of the recently implanted device. It's recommended that for the first few weeks that the focus is all on lower body movements. So both the aerobic and resistance training should be limited to lower body large muscle groups. And that's just to preserve the lead integrity of where the device is going to be implanted, okay? So again, note your intensity levels and everything that are in the tables, but that's kind of one thing that sort of stands out with this particular condition as far as the actual recommendation. So again, first few weeks, and again, that could be also in conjunction with the medical professional that they're getting treated by, can also kind of give some guidance on that, but that's usually going to be your recommendation. And then after that, their exercise prescription will vary according to the consistence of comorbidities, except that your heart rate should remain about 10 to 15% below the rate that would trigger the device to fire. Okay, so you're going to want to, if you could monitor the heart rate, and then this way here, you don't want the device to fire due to, a high heart rate with exercise. So make sure that you kind of know, you would be aware of that, and when you're kind of designing your intensity for the individual. And again, just, be aware of the symptoms that could result from device malfunction. So again, undue fatigue, syncope, dyspnea, dizziness, palpitations, tachycardia, or unusual bradycardia. So, that would tell you that, there could be a possible malfunction with the device for the individual. Okay, so now we look at valvular disorders. So again, a valvular heart disease is when you have incompetence of one or more heart valves resulting in reduced or inadequate blood flow and an increase in the pressure and in the size of the chambers of the heart. So they have various valves throughout the heart and through that region that could be affected. So the valves between the atria and ventricles can be affected. The valves between the ventricles and the aorta, or the ventricles and the pulmonary artery, or both. It may help in hearing a lot of this, with a lot of these conditions. Again, maybe just do a quick little review of kind of the heart anatomy. Would probably be something that would be helpful for most of you. But basically, you can have either valves that either stenose, meaning that they narrow or harden, or they fail to close completely, resulting in retrograde blood flow. So in other words, when those valves close, the idea is that the blood doesn't kind of rush back into whatever chamber it was in. In other words, the valve, for instance, if you look at blood flow into one of the atria, when the atria contracts, it pushes the blood into the ventricles, and there's a valve behind there that'll close. Well, if that valve doesn't close, you're going to get blood that will regurgitate back into that, and then they call that an incompetent valve when that happens. There's various causes of this. Again, rheumatic fever is something we don't have a whole lot of rheumatic fever in the United States, Rheumatic fever is a condition that where the heart valves actually get infected first. It's an inflammatory disease where the heart valves actually get, where they'll have negative effects on that first. There's also congenital issues. Again, various infections can do this, and also just aging in general. And typically your early symptoms of this, dyspnea, fatigue, pain, and heart palpitations are all things that would come about. The concern here is that there's possible structural effects that could happen to the heart over time. So you could have, because of the blood kind of regurgitating back, again, the long-term impact that you look at with these is maybe an increase in pressure and size in the chambers in the heart because of the blood kind of going backwards within the heart flow. So looking at your medications, again, atrial fibrillation and coronary heart disease are going to be your common comorbidities. So again, the medications are going to be kind of given to individuals based on that. So again, review all of your different medications. So we're just kind of going through, we have some of them listed here as far as what would be some of the things possibly associated. So again, you could look at what each one of these, which comorbidities they would be associated with. Some of these we've already talked about, but make sure to kind of take a look at all of those different types: ACE inhibitors, antiarrhythmics, antibiotics if there would be any concern about an infection, diuretics, inotropes, beta blockers, anticoagulants are all common things that you would see. And again, you have to look at what it would mean. Obviously, things like beta blockers, for instance, would affect heart rate. So those would be things you would want to consider when you're looking at these individuals who would be taking those. Again, despite possible side effects, many times medications will help improve exercise capacity, but again, valve replacement surgery may be necessary depending upon the severity of symptoms. And that's something that we're going to talk about as far as when you look at the effects of exercise and what they mean. Again, we're going to be looking at, what kind of symptoms. There's quite a range of symptoms that a person would possibly have with valvular disorders. So when we look at the effects of exercise, again, it's going to be dependent upon the type of valvular heart issue and the comorbidity severity. So if they have minimal symptoms, normal exercise training and response would be expected. So pretty much, what's going to, their response to exercise and the benefits would be the same as it would be for most other people. If they have moderate symptoms, their exercise response is probably going to be dependent upon the worst comorbidity. So whatever, comorbidity is going to have the most impact on their exercise. If they have severe symptoms, and particularly if they have symptoms at rest, exercise for the time could be contraindicated until they get treated appropriately for it. So if they have severe symptoms, they may be at a point where they can't exercise at all until some further treatments have been administered. So again, review all your exercise recommendations. Again, medically supervised testing is going to be recommended for these individuals. Aerobic exercise, large muscle group activities, 40 to 80% of peak VO2, RPE of 12 to 16. Again, 20 to 60 minutes a day, continuous or accumulated. Resistance training, they're recommending a little bit lighter intensity. Again, some of that is going to have to be based upon their symptoms. So again, and some of that will just be because obviously with higher intensities, you tend to have more pressure fluctuations, which could significantly impact wherever the valvular dysfunction is taking place. And again, comorbidities may preclude all resistance training. So again, or if they have symptomatic aortic or pulmonary stenosis. So those would be things that would possibly preclude resistance training. So if they have significant comorbidities, or if they have symptomatic aortic or pulmonary stenosis, that would cancel out any type of resistance training. And again, a longer warm up and cool down is recommended. So again, just to kind of make sure, again, longer warm up to build up to the intensity, And then the cool down, which, is kind of a forgotten element. We talk a lot about warming up, but we tend to sometimes neglect the cool down. But a cool down just to kind of, again, get their heart rate and everything back down to rest from the elevated intensity wherever they would be at is recommended. So to talk a little bit about some surgical procedures that are common, coronary artery bypass grafting. So when you hear of people having open heart surgery where they, again, they open up the rib cage, and what they look to do with this is they take a section of a blood vessel that gets grafted. Sometimes they'll use from the aorta. They also use it in less invasive versions. They will take it from the saphenous vein. Is another area. The internal mammary vessels they will use sometimes. The gastroepiglotic arteries are another one. But they'll graft a blood vessel, and what they'll do is basically create a bypass. And they'll do this if the lesion, so this is again for someone that has atherosclerosis, they'll do this if the blockages are great or if they've done less invasive measures in the past that haven't been successful. Another thing they will do is something called percutaneous transluminal coronary angioplasty. And this is a catheter-driven treatment where, in the case of, again, coronary atherosclerosis, where a balloon-tip catheter is kind of guided through, and then it's expanded to help reduce the plaque and kind of help restore blood flow. And sometimes they'll also place what's called a stent in the artery to kind of hold that open. So that's something that's a less invasive procedure that they will do as well. Obviously, if there's significant blockages, they have to go with the coronary artery bypass grafting. Both of these are treatments for atherosclerosis. Again, you look at your risk factors: hypertension, hyperlipidemia, diabetes. Past family history would all be situations where, these would be a possibility if was needed for someone. The medications, again, all medications that we've talked about in the past, I'll put these up here again. All the medications many times will be given for, reducing workload on the heart. So your calcium channel antagonists and beta blockers will do that. Those could also increase exercise capacity, but just the surgery in general will help with exercise capacity as well, because you'll be essentially having, more blood flow coming back to the heart. Obviously, if, in the case of atherosclerosis, coronary artery disease, those coronary arteries are getting blocked, the heart tissue isn't getting is basically getting ischemic, is not getting the blood flow. So just the surgery in and of itself could help with exercise capacity, but again, some of the medications, particularly those that kind of reduce the workload on the heart, will assist that as well. So looking at the responses to exercise after these, surgical interventions, again, if first of all, if the surgery and interventions are successful, both acute and chronic responses to exercise are near normal. The chronic aerobic training responses are the most relevant to this population, and that includes an increase in the arrhythmia threshold as well as other more commonly expected, cardiovascular and muscle functioning from such training. So again, you'll get all of those benefits. It's really important though with these individuals to make sure that you emphasize lifestyle changes. So that's going to be the biggest thing. They're having the surgical procedure done to correct this, but to make sure that problems don't come up in the future. Again, the exercise, obviously, and again, all of those benefits that you get, prior to and discussing will come about if they continue with that. The lifetime of the surgical grafts, that's something to consider. So when someone does have a coronary artery bypass, there is kind of a time frame that those grafts could possibly not be as functional. So it's about 5 to 7 years for a saphenous graft and about 20 to 25 for an arterial. So that's why it's really important for lifestyle changes to help maximize that that lifetime of the graft itself. So again, it's not a cure, but it's a treatment for a symptom. So that's why it's really important to make sure that lifestyle changes accompany the surgical procedure. So your exercise recommendations, so you can look at table 16.7 for the aerobic exercise recommendations. Again, medically supervised testing for both of these will be done at first. An initial exercise program will probably be done for the coronary artery bypass grafts. It will be done as cardiac rehab. So those individuals will start with cardiac rehab. Typically, the individuals with the angioplasty will typically do better, and they could usually exercise in a general fitness setting. So they don't need the structured cardiac rehab typically like the coronary artery bypass grafts need. So aerobic training 4 to 7 days a week, 40 to 80% of your peak VO2, 12 to 16 on the ratings of perceived exertion. Same thing as a lot of the other things, large muscle groups, 20 to 60 minutes of either accumulated or continuous activity. Your resistance training, 40 to 80%. Again, you can also look to do like possibly utilizing circuit training for these individuals. Again, about 1 to 3 sets per exercise and anywhere from 8 to 10 exercises. Again, there's really good benefits to circuit training for these individuals. And your objectives or your learning outcomes. So again, I would also suggest, I think some of your understanding could definitely be enhanced if you review your heart anatomy. We didn't talk about that at all, and I could mention a little bit about that in class when we meet. But certainly going back and looking at that, from the general strength and conditioning class, the 240 class, we talked about that. We talked about how blood flow goes through the heart. So that would be something I'd recommend. I think could help your understanding a little bit more of some of these conditions, particularly things like the valve disorders and stuff like that. It could help make a little bit more sense. And this is just the conclusion of the objectives.